Let's see.
So I will show to me, I think is the most interesting case that we had this week. I've shown a couple of these before. I just find it fascinating. This is a kid who was born, had a known congenital heart disease diagnosis in utero. You can see that there is basically a common atria. There is a normal left ventricle, but the right ventricle is very small. The tricuspid valve is hypoplastic. It actually it's not atretic, it's just hypoplastic. It was stenotic. And you can notice when you go from the RVOT that there's really nothing there. There's a pulmonary artery, but there's no connection between the right ventricle and the pulmonary artery. So here's the RVOT, and it just kind of ends. And then you can see up here that there is a pulmonary artery. So this is a pulmonary atresia. You can see a little dysplastic pulmonary valve. And most of these patients have a VSD. This person has an intact ventricular septum. And when you see pulmonary atresia with intact ventricular septum, it's, I don't want to say almost always or always, but every case I've seen, it's associated with these coronary sinusoids. And I'll show you what those are on cath, but you can see that there's a small little diddly RCA coming off here. There's no left main. And if you look at the right ventricle, you can see that there's all these little vessels that come out of the RV and basically provide the coronary circulation. These are referred to as, depending on which book you look to, as coronary sinusoids. You can actually see one coming up here, kind of branching and forming a left circ. And they did a cath because they always do caths with these. And hopefully this will play. And so they have their catheter in the RV, and you can see that when they inject the RV, basically it fills the entire coronary tree. So this is and I think I've shown maybe one or two other cases very similar, but it's just really amazing that, you can't relieve the right ventricular pressure. If basically the kid is dependent on that high RV pressure to supply his coronary circulation. So, they're going to provide, and you can see here, he's already had his BT shunt, and they left his he has a PDA. They kept the PDA open. But I always just find these fascinating. I still don't understand how these coronary sinusoids form, but they're invariably present. I've tried to look it up, and there's different theories. But that's a cool case.
Seth, one quick question: Do you guys use the term RV dependent coronary circulation for those? Because that's kind of what Charlie Higgins has tossed around here, and that's been.
So the answer is yes. They know that it's RV dependent. It is RV dependent coronary circulation, without a doubt. If you remove if you created a VSD, the kid would die pretty much. He needs that super high physiologic RV pressures, which were very, very high to survive. And it is RV dependent coronary circulation. I don't know if I specifically say that in my report, because these are mostly, they've had the BT shunt, they've already had the cath, they know that's the case. But
right.
But that is 100% correct statement.
Although I agree with you, I still find these kind of confusing, these cases, like the development of those sinusoids.
I just don't even, it's beyond me how it occurs. And this was a case that we've had, and I'll just show you, it's just a weird case. We're trying to correlate the spleen with the findings. You can see it's a relatively bigger person. And there's this patient has history of dialysis. She's renal failure patient. And there's this large thing here, which farther down, I'll show you better images, it connects down into this pouch, which I'll show you connects with the azygos, directly fills from the azygos. And then vessels come out of this and feed into the left atrium via, I don't know if it's a direct communication with the pulmonary vein or just directly feeds into left atrium. There's a better case, I think. Let's see which one has the test injection. So this is neat because this shows the test injection, and you can see that, if I can get it to go through, that literally when the azygos fills, that this thing just completely fills up with contrast almost immediately. And we think that the spleen is sarcoid and completely unrelated. We asked our body guys, we couldn't figure out a way to kind of bring the two together. We've done MRs on this. We've been following this for many, many years. And it's just an interesting, because initially it's been called hemangioma, and it kind of brings up the question, and these calcifications, I think some are sarcoid related given the spleen, but they could be related to this, some down here definitely related to the vascular malformation. And it brings up the interesting and extraordinarily confusing terminology with these vascular malformations that, now they're considered high flow and low flow, and hemangiomas, which this is not, are kind of low flow, and this would be a high flow vascular malformation. But we've been imaging this thing since 2006, and it just hasn't done anything. Her spleen's gotten more filled with her, probably her sarcoid, but of course no one wants to touch this thing. And it's just a weird vascular malformation. And then this is an unfortunate case, and I have a chest x-ray, which I will include at some point in time. Sorry I don't show it. And this is, a miss by one of our guys where I don't understand. Everything is in hindsight 2020. They mentioned this thickening here. They thought it was maybe post-traumatic from a prior trach or related to the thyroid. It's kind of circumferential, ugly thickening. And the patient, unfortunately, disappeared for follow-up for quite some time, and came back and had a much larger mass. And yeah, and I have all PET imaging, and not to waste anyone's time, but this is a young patient, a non-smoker, and we often think of adenoid cystics, but and that's what we're always taught. But this was a primary squamous of the trachea, and I'm never surprised how many, even though we think of older smokers with squamous, how often I've seen even young patients present with squamous who are non-smokers. But anyways, bad news. She's still alive. And the last, really quickly, this is just an interesting case.
That's interesting because usually the squames, it looks like it's intrinsically narrowing the lumen, but it's not actually involving the mucosa.
Yeah, no, I agree. More squames tend to be more erosive and ugly looking. This one kind of, to me, looks more exophytic and narrowing. And the squames I've seen really invade, and they just make the trachea look very ratty and not just narrow it. Right. I don't know if that's a good word, ratty, but
yeah, I know. It's a little unusual for a squame, because when you showed it and said it was coming back, I thought it was going to be an adenoid cystic, not only because of the age, but like they typically look.
No, and we thought it would be an adenoid cystic. Everything was right for it to be adenoid cystic. It was the right age, young female, non-smoker, had the appearance, but it came back, and it was definitely a there was no doubt about on pathology. It was clearly a squame, which was surprising. I won't waste time with the PET, but the PET shows the intense avidity there. I'll let people look at that on their own. And real quick, this is just a really interesting case. One of my old fellows sent me, Jay Lev from Columbia, and this is a patient. I don't know if the patient had a concern for a shunt, but a big RV. And let's see if I can find the necessary. So if you go onto, first of all, there's anomalous left upper lobe pulmonary, or PAPVR, anomalous left superior pulmonary vein to the brachiocephalic. And then you could see here that there's this communication between the left inferior pulmonary vein, and it kind of looks like it's going into the left atrium, but it actually goes, if you follow this down, it actually goes more into the greater cardiac vein slash coronary sinus, and then is associated with a connection to the left atrium. So it's more acting like a unroofed coronary sinus, but it's like a direct communication between the pulmonary vein. I'm trying to see if I know I have other imaging that shows it better. It's like direct communication between this pulmonary vein and the coronary sinus, which then communicates with the left atrium. So it's just an interesting variant of unroofed coronary sinus. It's just not one I have seen. And you could again see the massive PA, big right heart, and she had a pretty significant shunt fraction. So just an interesting case. But those are
all right.
Those are mine.
Thanks. Okay, Travis, do you have any cases this week?
Sure.
All righty.
All right. Well, I showed some aortic arch cases last week, and I love the fact that I kind of summoned this case to pop up. I feel like this always happens when I haven't seen something in a while and I talk about it, that it shows up. And this is one that is from yesterday. I didn't just pull this out of nowhere. But I'd made the comment, and Jeff, I don't know if you went back and looked at any of your right arch mirror image branching cases, but I'd said that even, that the literature suggests that most of the time you have a left ligamentum, even if you have a right arch of situs inversus totalis. And here's a case that one of my residents had added to our teaching file from yesterday of mirror image branching with a right arch. This is a patient without congenital heart disease. And of course, you can instantly see that you've got a little, sweep here. So this is definitely, I think, a circumflex arch because it passes behind the esophagus and the descending thoracic aorta descends on the opposite side. But what's really cool is you can see the calcified ligamentum right here, and it's clearly along the left side and arising from the descending thoracic aorta. So he's got HIV. He's had prior intracranial bleeds and whatnot. So he's not, I have no idea if this has ever caused symptoms. It's not reported to, but I think this is the best example I've seen of a clear-cut circumflex aortic arch. And again, this idea that it's not just a true right arch with mirror image branching, in the sense that there's a left ligamentum. And this could have conceivably caused symptoms, probably not in him though. What do you guys think? Agree?
Agreed.
Yeah, circumflex, yeah.
So let me see. This one, I've been going through a lot of our cases that we have of connective tissue disease and looking at cardiovascular stuff. This is interesting because this was a coronary CTA. This is a lady with lupus, and you can see she's got a pericardial effusion, and this is on a coronary CTA. She was an inpatient at the time. She's got a dialysis catheter, and clearly this is not a run-of-the-mill pericardial effusion, that she's got 40, 50, 60 Hounsfield units. Looks like blood. And this is super sneaky, and you can see it right at the aortic root. But she's got a focal dissection flap at her aortic root, as you see here. And it's interesting that it approaches her left coronary. But this is one that I've seen a couple of like these focal aortic root tears. And it's interesting too that she has this, weird discontinuity. It's like it's a complete circumferential tear at her root, but that's as far as it goes. And she ended up going to surgery and getting this fixed, luckily. But I just thought it's a good example of a really subtle, dissection just involving the root, and how if this were a PE study instead of a coronary study, how easy this would be to pass over. And yes, patients with lupus do have increased incidence of dissection and of aneurysms in general, which it's unclear if it's just from their increased incidence of hypertension or if it's unrelated to that. But I don't know. This is the scariest dissection I've seen in a while. So, yeah, and on unsuspected on a coronary CTA. So,
Did she have chest pain? I mean, was it like a chest pain?
I think so. Yeah. That was what it was. Yeah, it's an old case, but I just found it and thought it was a good one. Now this one's kind of interesting. One of my residents at the VA, and this is a patient who has undergone he just underwent aortic valve replacement through a median sternotomy, and of course they called. They've already sewn him up, but they had an incorrect needle count, which makes me wonder why they had already sewn him up, because they, you can see, maybe you've recognized that there's a subtle, tiny little needle here. And obviously having the history is critical in this case. But I don't know if you guys do this. We've been doing this more, and we've started doing it at Emory too. And I know they're doing it in St. Louis, but this practice of having an x-ray of whatever type of needle is missing. I think in this case, it was really helpful because they include this with the image, and then you can see what you're looking for. This is like a little 7-0 Prolene needle. Do you guys do that? Because I think it's a pretty good practice.
No, it's very smart. I never even thought of doing that.
Yeah, and then so they, I guess they didn't believe us because that's why, or they wouldn't have closed him up. But here, but then of course that he's now undergone a redo sternotomy. This is a few hours later, I believe. Yeah, this is later that day, 4 hours later. So they reopened him up while he was still in the OR, took out that tiny little needle that was right there, and then closed him back up. You can see different sternotomy wires. So I just thought it was, I think that's something that more places are doing. And this is the best example, I think, of it actually helping. Because with big needles, it's not an issue, but these are tiny little 7-0 needles. So that's my anecdotal evidence that this practice helps. And then I want to show this just to get everyone's opinion, because this is one from yesterday, and this is a guy who has bronchiectasis, and this is one of those ones where I don't know if we'll have an answer or not, but his trachea looks a little funky. It's a little corrugated, and he's got bronchiectasis. And the question is, do you think this is more likely Williams-Campbell or more likely tracheobronchomegaly? And his trachea doesn't measure all that large. It does have a little bit of an abnormal configuration, but
his main stem is huge. That left main stem is massive.
Yeah. Well, the left is definitely huge. That's why, but the right is not as big. And then you look at the lobar bronchi, and they are big, but they're not humongous. I don't know. I was on the fence, but
I would think Williams. I would think tracheobronchomegaly.
Tracheobronchomegaly.
Yeah, that's what I would.
Yeah,
that's kind of what we were thinking too. But
spectrum anyway.
Hey, Travis.
Yeah.
I agree with calling you morning or Coon, but can you put up the coronal, because it may be dramatic on the coronal.
Yeah, I always measure these truly transverse to the short axis of the.
It looks like that's very abnormal trachea, distal trachea, and main stem bronchi. So more.
And
okay, good.
Part of the scalloping fits with Meunier-Kuhn more than it does.
Right.
Even though it's not big.
I just never. Right. And Jeff, like you had said, that they may be part of a spectrum. Is that what you were?
That's
comment
kind of
you
what
made
I think about it, because a lot, and the problem is a lot of times if you get bronchiectasis first, you can get tracheomegaly or scalloping, sort of as an extreme phenomenon. And if you got somebody with a collapsible trachea, they can get bronchiectasis. So it's kind of an endpoint common injury, sort of multiple injuries leading to an endpoint. But in the literature quotes Williams-Campbell of most cases reported within the first year of life. But I mean, I've seen cases of adults that would meet the criteria, and then I've had cases like yours that don't quite have a tracheomegaly, but they have sort of a bronchomegaly.
Yeah, it's an academic question, I think, but yeah, I just wanted to get everyone's input, since we occasionally have these that we argue over, or not argue, but debate. Let me find this other one. I want to show you, just because this was a quick little pitfall. This is one that this patient has. Well, you can see he's got fibrosis, and this is pre-lung transplant. I'll show you his. This is a couple days post-lung transplant, and as you can see, he blew up like a balloon. He's got pneumomediastinum. He's got extrapleural air, probably a little bit of pleural. Well, he's definitely got pleural air as well, and then subcutaneous gas. And so they were doing this I don't know if they were looking for an injury or not, and somebody saw this and questioned whether or not this was a bronchial injury, which this location's a little weird because it's not near the anastomosis. I mean, maybe they could have injured the airway, but there's not even a lot of gas right around that. But the point of this is just to show, obviously look at the prior studies, because this one, as you might suspect, is just a little bronchial diverticulum that happened to be right there, which I think is kind of cool. So usually we think of tracheal diverticula or these paratracheal air cysts at the thoracic inlet, but you can't see them elsewhere, especially in patients with lung disease. So I thought it was nice to have the before and after, just to not make that mistake of confusing this with something more sinister. So, and all the pneumomediastinum and everything, not surprisingly, went away pretty quickly. And this is just the more recent follow-up to show that thing is still there. So, I don't know, not that exciting, but a common finding that we see just in a slightly unusual location. So, all right, Jeff, I'll stop there for now. I've got more if necessary.
All right, cool. Yeah, I'll show a few. Let's see here. Well, we'll go along the congenital route. Let me pull these up and show this. So this was one I came across because I was reading a chest radiograph with one of my residents, and just thought the azygos was a little plumper than usual. I think this is the right image, but it was just a little fuller in there, and I think we had a comparison that it showed a little bit more conspicuous. And then what was cool is the abdominal CT, and you can see the azygos is quite large, which usually is because of IVC obstruction or something. And we were going down looking at it, and we noticed that the liver looked really kind of funny. I'll change the window a little bit for you. Just this weird orientation of the portal system. And then you'll notice we've got a spleen, and then we have another spleen hiding behind it with its own hilum and own pulmonary, own splenic vessels here. And then you'll see there's no infrahepatic inferior vena cava. So this is an azygos continuation of the IVC with polysplenia. But what's really cool is you've got all the colon here on the left and all the small bowel on the right. So this also has a malrotation. This was a 57-year-old, so this was an incidental finding in this patient. So I mean, not really a chest case, but we do have we do get to see the big azygos vein here, and then has this funny little cyst here just up for fun. So if this follows my rule, this is some sort of duplication cyst of some sort. So, but just kind of a fun congenital case, and then another congenital case to go with it. This was a pediatric case that was shared with me. Let's see. So this is a child who presented with breathing problems, and this is the CT scan. And you'll notice the trachea is very tiny, very, very tiny. There's a feeding tube in, unfortunately causing some artifact. And we don't see much else in the lungs, but I want to draw your attention to sort of the airways right here. It looks very very thin. This is the virtual bronchoscopy, and you'll notice that there are complete tracheal rings going all the way down. It's not the best bronchoscopy, but considering the noise on the scan, but you can indeed see there are complete rings. This is posterior here, so there it goes all the way around. And then what's really cool is you can see there's left isomerism. It doesn't. I tried to show on the coronal here, make a coronal, but you have bilateral hyperarterial bronchi, assuming it's going to let me be sliced. There we go. And you can see there's one airway under the artery, and there's the other airway under the artery here. So has two left lungs and complete tracheal rings, no pulmonary sling, and has a sort of a small trachea. And I don't know what they can do for these. It's there's not a lot of options as far as the trachea goes to improve it. But I mean, you can try to do a plasty of the trachea and really do something, but it's a pretty tight trachea. So congenital. This is something I came across yesterday. I don't know if any of you have ever encountered this. Here we go. So this was from the EP lab, and when I first saw this, I thought to myself, well, gee, these event recorders are getting smaller and smaller. But this is actually in the right ventricle. This is a Micra. It's called a leadless cardiac pacer, and you can see it kind of looks like a little spaceship with these little tines. And so what they do is it's actually a catheter inserted device, and these tines can be retracted, and then they embed it in the right ventricular myocardium. And then as they, with the deployment device, they can actually pull back, and it causes these to hook in. So this is pretty tightly secured. This is the cathode here, and this is the anode here, and it's able to, and there's the battery. It's able to pace just the ventricle, just the right ventricle through this method. I have the cath images of it. They're not all in order, and I don't think they saved them all. But you can kind of see what this thing looks like. And they use contrast to make sure they're up against the wall on that image. And then we got this one. They're just checking their location there. Let's see if I can find one where they're actually deploying it. Yeah, you can see there it's been released from the, and they're withdrawing the catheter there. Unfortunately, when these came to PACS, they didn't. But they're the little tines. And if you, so anyway, it's kind of a cool thing. I don't know if any of you ever seen one of these before.
No.
Yeah,
I have not.
It's a new device.
I showed one a couple of years ago. I think it was, it's been a while.
Yeah.
If we have a ton of these floating around for some reason, so we come across a couple every day. So
is that the one? Is it made by an Atlanta company, or was that the?
No, it's made by I think it's made by Medtronic. Yeah, Medtronic. Yeah.
So it's that other little thing that they put in the pulmonary artery to measure pressure. That's like made by a company in Atlanta. Maybe that's the one I'm thinking about.
Yeah. Okay.
Yeah, that's called
the CardioMEMS.
This is a pretty classic case. It's a good resident fellow case, something we see every so often. Patient with hypercalcemia, looking for hyperparathyroidism, looking for adenoma, and they do the sestamibi scan. You can see the submandibular gland, thyroid uptake, and then of course.
If I don't see your, I don't know if it's me. I don't see your screen.
It's got to be me. Sorry. Try again. There we go.
Yeah.
Yeah. So you see the normal uptake in the thyroid, submandibular gland, and they do the interesting. I don't have them unloaded, but they did an iodine subtraction where they did sestamibi and iodine 123 and subtracted it out and saw that there was nothing in the thyroid. But at the very bottom of their field, you can see there's this uptake. They did some SPECT imaging. So this is the SPECT. So there's the physiologic thyroid uptake. And right here in the anterior mediastinum is some sestamibi uptake. And then we got the CT correlate to go right there. You see this enhancing nodule. So that's a parathyroid adenoma. And it's a common location. I've seen it probably half a dozen somewhere along the anterior pericardial surface. They can be anywhere in the anterior mediastinum, but nice to have that correlate.
I mean, without contrast in that history, I mean, it just looks like a little node. I mean,
right, exactly.
Usually they're all, you always have that. Fortunately, they're always looking for it. But, man, I always find those without contrast tough.
Yeah. And let me just show one more here. I think you guys will like this one. This is probably the best one. So this was a guy, and the story goes, he's a young guy in his 40s, and his son, who is not of driving age, was driving his truck, I think, into the garage and hit the wrong pedal and ended up crashing into the patient up against a wall or something like that. And he was transferred for trauma. And he's got, you can see a lot of subcutaneous gas. But I want to show you this right here in the ascending aorta. You'll see there's a flap right there. I'm going to make a coronal. Actually, I have a coronal, but you can just see that indeed this is a very localized injury, but it's a pseudoaneurysm of the ascending aorta. And then on the sagittal, I want to show you, and he's got fractures of the ribs, but this is one of the most impressive sternal fracture I've ever seen. It's a clean cut with a distraction. So it was, and it's right, not too far from that pseudoaneurysm, which is right out here. So it must have been a direct hit to the sternum there. But, these are really rare. I saw one as a resident at Harborview in Seattle, and it was an ascending injury, but this is it. And you can see he's got just extensive, and actually the pleural drain he was transferred with goes into the pleural space and then back out into the chest wall here because he had just disrupted so many of the ribs. Obviously has all the other injuries associated with it, but I don't know. We don't see these very often that survive, probably because this is just a tiny little pseudoaneurysm. They have not fixed it yet. He's still very ill, but hopefully they'll be able to fix that soon. Now, Seth, well, you don't see all the traumas necessarily, but have you seen a ascending injury?
Yeah, I think I showed one maybe 4 or 5 months ago. A guy had a massive tear at his root, and it was a trauma case, and he somehow survived. I mean, as you say, I mean, this guy I still don't understand how he was alive. It just walled off, but
yeah,
this guy had a legitimate, like right at the annulus sinus level, just a near transection, and he didn't die. But that's the only one I've ever seen.
Yeah, they're not very common. Okay, I have a couple more, but if Travis, you want to show a few more, we have lots of time, but we can also end early. Save them for
you
next.
You can keep going.
All right,
keep going, and I'll prep a couple.
All right, I'll show. Let's see. I'll just show. Let's see. I think this one's quick. Let's see here. So this is a guy with Marfan Syndrome, and you should see some CT images now. With Marfan Syndrome, who had an ascending aortic aneurysm repair. So this is him post-operatively, and you can see there's some fluid around the graft. There's part of the graft, distal anastomosis, but the graft was intact. He apparently was non-compliant with his blood pressure medications, and this is him a year later. So you see there's still fluid around the graft, but he developed this collection right at the distal anastomosis here. So a pseudoaneurysm there, and thought to be from uncontrolled hypertension, at least exacerbated by it. And so he's got all this more fluid around here. There's his aortic valve. So they went in and fixed this and dealt with that there, but just a nice anastomotic leak in a Marfan patient. You'll note the pectus narrow diameter here that goes along with that. And then this is one of my colleagues shared this case with me, just a classic case of constrictive pericarditis, and I'm never going to find the right sequence. Let's see, I need the short axis, but it's got the, let's see, that's the flow, and maybe it's this one. Grab the one of those. Let's see. No. I'll find it in a second. But it had a beautiful, we got him during respiration. Here's the cine. Let's see if we can see it here. But if you watch the septum, we might catch it.
That's the TI Scout.
Yeah, that's not what I wanted. I always load the whole case here. Let's see. Here's one cine loop. Yeah, you might see it on here, but you'll see there's straightening of that septum, and there's thickening the pericardium. They actually did some tag sequences too, as you can see. But what's great is this guy has a history of tuberculosis. So this is tuberculous, constrictive pericarditis from tuberculosis. And we have a couple of images, and I'll see if I can find them real quickly. Well, here we go. Yeah, this is while he's breathing. You can watch.
Yeah, there.
Yeah, that's good. Right there. Didn't have the septal bounce you often see, but we got him at different points taking a breath. Here he is breathing, and you can see it changes with the breath. But I included the whole stack, so you can go through them, and I believe there was some delayed enhancement somewhere in there with the pericardium, or at least pericardium. The way they label the studies here makes it very hard for me to find them. Yeah, here's that's not what I wanted. Anyway, it's a nice case you can use for your files. All right, Travis.
Okay, unless Brent has anything, I heard him on there. You guys see my screen?
I see him. That's why I'm confused.
You see my screen?
I do.
This is an interesting case. Now, a couple of years ago, I showed a case from Grady of a guy that had gotten shot through his LV. The bullet ended up in his RV, and he presented a couple months later with heart failure from a big acquired ventricular septal defect. This one's similar, but it's not quite as severe. And this is a guy that got shot, and you can see a lot of the fragments are along his left chest wall, and he's got one little wire in here. They had to go explore him. But I saw this in one of our cardiology follow-up conferences, and you'll see that in him that they took out some of the bullet. I don't even remember. I guess maybe he got shot here, and then it went through his liver and up into his heart. But regardless, he had an LV injury that was repaired. But of course, you see that he does have one little fragment in his RV that nobody could really account for. But you can actually see the ventricular septal defect right here. He came back with a murmur. They did an echo and saw a little VSD. So I think he did get shot posteriorly. Yeah, and so most of the bullet, stopped in his LV, and then one little fragment perforated through here, rested in his RV. And so the plan was, this was only a couple weeks after he got shot, that they were going to wait and let this settle down for a few months, see if it healed, and if not, go in and repair his ventricular septal defect. But you can definitely see that there's a little tiny muscular acquired VSD in here. But it's just, I thought it was a puzzle that you can kind of put together looking at the CT, knowing that he got shot in the back and that this bullet fragment had to come from there, unless it had embolized, of course, but you can see the VSD in this case. I think, Seth, didn't you have one, or was yours from a stabbing where you had acquired VSD?
We've had multiple stabbings with VSDs that were acquired. It's a trend here, to say the least. So here's one. I just pulled this one up after, Seth, you had shown the first case, and this is another patient who has pulmonary atresia, intact ventricular septum. And I don't remember how old they are. Let's see. They're 28 years old. But this is one where you can see the big sinusoids, or whatever you want to call these, off of the RCA and off of his left coronary circulation too. That his left main is here, and then his LAD kind of, it kind of peters out right in here. But there's definitely a big communication. I thought I had a better series than this. I think I do, actually. I think we had 2 studies in this guy. Yeah, this one's better. This one has less motion. This was a gated study, and you can actually see the frank communication between these. So and like I said, I still don't fully understand these, other than the idea is that there's a higher pressure in the RV perfusing these coronaries, and so that's why you don't decompress this. Otherwise, they end up with lack of perfusion. Yeah. No. Exactly.
So so this is another case, and they knew about this, that this was RV dependent coronary circulation. I think this is a good example too of just filling defect, flow artifact from having a Fontan circulation and not tracing where the contrast goes and waiting, with tons of collaterals in the mediastinum. So I just wanted to pull that one up and show it. So it's another case of the RV dependent coronary circulation in the setting of pulmonary atresia with intact ventricular septum.
Cool.
All right, let's see what else.
I can show a cool case. It's an old case. I don't have DICOMs, but I can show you. This is from my residency, and this was a guy who he made his girlfriend mad, so he shot him in the groin with a shotgun. It was the first and only rug I've ever done. But the thing that I want you to notice are these little pellets here, and I didn't understand on chest x-ray. We had a chest x-ray before, how they got there, because I said he must be shot in the chest. But you can see that he has these pellets in his RV, and some of them had embolized into his lung, and they got there through, again, this is a very old study, but through his gonadal circulation. Basically, he just got shot in the groin with a shotgun, and there was just a mess down there, and the shotgun pellets embolized from his pelvic circulation, his groin, into his heart, and then into his RV. So these were pellet embolizations so don't anger your girlfriend, at least in Denver. So that was an old case. I figured.
Yeah, right, and the point is too that I think we probably miss a lot of these too, where you just see shot fragments and you assume they got shot in the chest, but it's just like a prostate embolization or prostate seed embolization.
Yeah,
that's a good one.
Yeah, it was I remember that guy's name, very familiar. It's funny, these cases that you come across, you just don't forget.
All right, thanks. Travis, did you have another one?
I've got more, yeah.
Okay.
I have a couple of cases. I had to go away for a consult during the time of arrest.
let me show this one really quick. Somebody showed an iatrogenic dissection a few weeks ago, and this is one, and I think we were talking about other AFib ablation complications, like David showed the diaphragmatic paralysis. And this is one where it wasn't an AFib ablation, it was some sort of ventricular tachycardia, but they had done a femoral arterial puncture, and so it wasn't just a venous puncture, and they punctured both groins, and they noticed after a few passes that they had difficulty passing their wire, and may have even seen, I think they saw a dissection flap on echo. But what's interesting is this is the non-con, and you know, I don't see anything that looks like an intramural hematoma here, and certainly no dissection flap. But here's the arterial, and you'll see that there is, and this was presumably their wire dissected in the right femoral artery or in the right external iliac artery, and they ended up with, you know, a dissection that goes all the way to the aortic root from their catheter. And the only reason I pointed out on the non-contrast is this never fills in really with contrast, and so I don't know if it's, you know, I mean, it doesn't matter if it's a hyperacute intramural hematoma that's just isoattenuating, if it's, you know, a dissection that's starting to thrombose, whatever people want to say. But anyway, he did end up going to surgery and had a median sternotomy and had his ascending aorta replaced as a result of this iatrogenic dissection from ablation. So I just thought it was a pretty impressive. I don't know how far up their wire actually dissected, like if it injured the artery here and they just kept going, or if they just created a tear inferiorly and then the tear just propagated into the aortic root. But pretty dramatic iatrogenic dissection. I don't know if you guys have any thoughts on that, but
makes sense.
Pretty scary.
All right, I'm gonna let the people in Augusta, they have like one cardiac case, and then Brent, you can close out the meeting with whatever you have this week.
I gotta take off, guys.
I see you, Seth. Thanks.
See ya.
So you just have to hit the show my screen button, should work. All right. Well, technical difficulties. So Brent, which login are you at?
Which login?
Yeah, I don't see you on the list.
Oh, let's see.
You're under login.
Are you under art?
Try now.
Oh, okay, you did it. Okay. Okay, let me see. Okay, let's. Let me bring this up. Okay, let's see where my window is. Okay, okay. Is my screen up?
We see your CT.
Okay, good. Okay. So this is a case of a woman who was having some chronic shortness of breath, and you can see that you know, this is just the finding alone is not very interesting. We have this large, very enlarged thyroid with it's very heterogeneous. It looks like goiter. It's compressing the trachea, and you can see that it's a predominantly extrathoracic compression. And so this patient was having some chronic shortness of breath, and the interesting thing here is that we have, it's very hard to find examples of this particular pattern on PFTs, but we happen to have the PFTs of this patient. And here's the curve that we pulled up. And I have to just rub this in a little bit by saying that this was called normal spirometry. And this was kind of overlooked by the pulmonologist here. So here's a case of it's how important it is for the radiologist to realize what basic PFT patterns look like. And you can see that here's the flow volume loop here, and you can see that here's the expiration part of the loop, and here's the inspiration part of the loop. And at expiration, there's this plateau of the curve. It looks flat right here. and there's this decline here. And then on inspiration, there's also the plateauing of the curve. And so this is a nice, really nice example of fixed large airway obstruction at PFT. So you have resistance and plateauing at expiration and plateauing at inspiration. And you can see that fits with this, large goiter with narrowing of the trachea. So it's just a very nice case of fixed obstruction. And let me see if I can pull up. Well, I can't pull it up, but that's what a fixed obstructive curve looks like at the flow volume loop. So I just thought that was interesting. Here's another case, just a quick case. I'll pull up the radiograph first. Let me pull up the screen. Okay. So you can best see this on the lateral view, but this patient has a, let me show you the frontal too. Hiding here on the right is this tricuspid annular ring, and this is a relatively young patient, and I believe in his late 20s, and had been having some chronic shortness of breath. And this is a chest X-ray that was done actually a couple of years ago, and you can see that there's something kind of funny about the way this annuloplasty ring looks. It looks like it's kind of deformed, especially in this region. It's not like a fully formed annuloplasty ring. And I'll show you this is a CT that he had done just recently. And he's having what looked like wide open tricuspid regurgitation on the echo that he had done. And there was also apparently a funny kind of hyperechoic finding in the middle of the tricuspid valve plane. And so you can see here that the tricuspid ring is right here. The tricuspid valve plane is here. And this is dehisced from the lateral wall, that anterior wall of the tricuspid valve ring. So this is a completely dehisced tricuspid annular ring where there was free insufficiency through this part of the dehiscence. So that was dramatic, and it's probably been around for a while based on this morphology of the ring on the radiograph. So I thought that was. Have you all seen similar cases where the morphology suggests that on the annuloplasty ring?
Not that I've noticed. You're right that it's usually more D-shaped. That one looks like it was bent or something almost.
Yeah. So just very strange.
But,
so,
Brent, do you think that if it dehisced, do you think that the annuloplasty maintained that shape and just peeled away from where it was supposed to be sutured? I mean, I think that would be an impossible or very difficult, thing to suggest on the radiograph.
Oh yeah.
I don't know.
I agree. I mean, I didn't actually look. I may have actually read this, and when I did not comment on this if I read it or nothing was commented on. I don't know that I would really suggest that on this, but I think in retrospect it may be something that's I'll have to keep looking at these and see if there's anything that if others ever look like this and remain intact. So yeah. And then here's a bizarre case. I just wanted to see what people thought about this case. This is a woman who's in her, I believe, mid-60s, who had a murmur over much of her posterior chest on on physical exam. Oh, let me make sure I'm sharing this. So she had a murmur here, and you can see that there's something going on here posteriorly on the right, posteriorly, and you can see that there are these multiple tortuous arterially enhancing structures here, and you can trace this to the aorta where a intercostal artery may come off, and you can trace this around back to the portion of the azygous vein right here, and it seems to drain right into the azygous vein. And then there's a lot of flow here within the azygous vein. So presumably this is a arteriovenous fistula between, an intercostal artery branch and the azygous vein. that's causing this. And she's had some progressive shortness of breath. And the thought is, could this be embolized? Would that improve her shortness of breath? You can see that the pulmonary parenchyma, there are no abnormal vessels there. So it's just this isolated finding. So I was wondering, and you can see on the on one from, that was the most recent one. Here's one from 2013 where you can see it, and it wasn't commented on at the time, but it's there, and it's enlarged compared to this particular exam. So it's enlarging over time. And have you ever seen that particular arteriovenous fistula type?
No, Brad, but there's something funny going on the left too. Look at the intercostals on they're a little juicy.
Right. Yeah, they're not normal on either side. So I was just kind of racking my brain to, this patient had a remote history of apparently pulmonary emboli. I was trying to tie that in. I couldn't really tie that in. The pulmonary arteries don't really look abnormal or truncated here. So I don't know what's going on here really, because these are not normal either. Right. But the pulmonary parenchyma, the parenchyma here is not really that abnormal. I mean, you can see that the vessels are going, too distally. There's no liver disease to suggest any sort of, hepatopulmonary syndrome or anything going on in that, with that regard, but there's something diffuse going on, and there's something more focal, and just wondering if anyone had any ideas.
No, I don't know. It must be just a congenital pathway that took the path of least resistance, but it'd be interesting to look at it a little closer and see what's going on the left there. There's a lot of vessels back there.
Yeah. It's very bizarre. Okay. So, and then let me just show one more.
Yeah.
Okay. So it looks like, so I'll just wrap up with that because it looks like the Augusta folks are going to go now.
All right. Thanks, Brett.
Okay. And which screen should I?
Click this.
There we go.
Okay. So this is a 73-year-old patient who initially had an echocardiogram and had significant left ventricular hypertrophy, more than his blood pressure would happen. And there was some speckling, and that's why they ordered a cardiac MRI. And so basically, we have a Sinus sequence here. And basically what we are seeing is biatrial enlargement and severe left ventricular hypertrophy and some right ventricular hypertrophy. And after this, the patient also, we did some sequences to see for any edema or fat. We did not see any of that on these sequences. And patient then got delayed enhancement images. He could only get 12 ml because of his creatinine and GFR. Despite that, we could not null his myocardium. And there is some patchy enhancement of the subendocardium. Can you still see the screen?
No, we just see there we go. Now we see it again.
Okay, something happened. It's crashed. So I will show you some more short axis sequences. Patient since then has had a biopsy, and he is proven to have amyloidosis. So amyloidosis, I'm told, spares the apex more. So the apex of the myocardium is not as enhancing, and we are able to null the apex better than towards the base. So you do see more subendocardial enhancement, and in a non-ischemic pattern in a patient with very thickened ventricles. And they're doing more further analysis on the amyloid protein biopsy on the myocardium to see if they can catch. He has no known history of multiple myeloma either. So it's a fairly good case of amyloidosis. We, I think, get more negative cases than positive cases often. So I wanted to share that. And if you have time, I will just show one simple case. This was a 22-year-old last about 2 years ago, came in with injury to the heart from a nail gun. And this is on his lateral radiograph. So it pierced his right ventricle, and luckily he could come to the hospital and get it repaired and survived the accident.
Wow. Okay. You got lucky.
Yeah.
Well, thank you for.
Yeah. Yeah. Thank you.
All right, everybody. Thanks for the great cases. And I think I have a conflict next week, but either Howard, David, or Travis will run the webinar. So have a great rest of your week and weekend, and talk to you later.
Yeah. Thank you.